A very good evening to everybody and welcome all of you to the 73rd live webinar on orthopedic principles. Today, our guest faculty is Dr. Rishi Dhir from the United Kingdom. Dr. Dhir is a consultant orthopedic surgeon at Princess Alexandra Hospital, and he's the CEO of the organization called as Let's Talk Doctor, which is an organization exclusively for FRCS training programs. You all might have seen and listened to him at various platforms. He speaks at different courses all over in the UK. So today, it's my honor to introduce you to Dr. Rishi Dhir. Over to you, Rishi.
Thank you very much, Hitesh, and thanks to everybody listening in India and around the world. I hope you're all safe with COVID, and thanks for staying up so late. So first of all, I'm going to talk to you guys today about rotator cuff disease, which is a topic very keen to my heart. It's an area of my normal practice. I meet these patients on a day-to-day basis. But the one thing I've got to say is I'm going to talk to you about rotator cuff disease for the FRCS exam, because the topic itself is so vast and expansive that it could actually fill a whole series of international meetings. So I'll try and give you some of the key points, but really just for the exam, if that's okay. So what we're going to talk about, first of all, guys, I have no conflict of interests, and I'm going to break it up into different parts, which I think you guys need to know. So we'll look at the anatomy, the biomechanics, and mechanisms of how rotator cuff injuries occur. I also want you guys to be able to recognize these patients when they come in your clinic and how they might present, because recognition, detection is the first step before you treat these patients, and it's the most important. You need to be able to classify them, but I would say a relevant classification that affects your management. And finally, we talk about management itself. So epidemiologically, if you took a whole series of MRIs of every patient in the population, you'd find that a lot of people would have asymptomatic rotator cuff tears. So over the age of 60, about a third of the population have got rotator cuff tears. Over the age of 70, about 65% of people have got rotator cuff tears. And prognostically, these tears often become symptomatic if they're asymptomatic within about 2 to 3 years, and full thickness tears can progress within 2 years. Typically, the bigger tears progress farther. But the take-home point is, a tear does not necessarily equal symptoms and is often age-related. So let's move on to anatomy, and it's really important that you guys get an understanding of the anatomy of the cuff. Whereas in the textbooks, we think of the cuff as 4 separate muscles, in reality, when you visualize it under an arthroscope, it's actually a continuum of 4 muscles, hence the name cuff. And you've got supraspinatus, which essentially initiates abduction, but is actually really a depressor of the humeral head. So that's the way I want you to think about it. You've got infraspinatus and teres minor, which are external rotators, and subscapularis, which is a powerful internal rotator. Biomechanically, you can break the cuff up into a superior cuff, which is the supraspinatus, an inferior cuff, which is infraspinatus, teres minor, and also the lower part of subscapularis, an anterior cuff, which is subscapularis, and a posterior cuff, which is infraspinatus and teres minor. So that's how shoulder surgeons often refer to the cuff, as superior tears, inferior tears, anterior or posterior tears. That's what we're referring to. The other thing to remember is the infraspinatus muscle is actually what's known as a bipennate muscle, which means it's got 2 different types of fibers. Superior fibers, which run in an oblique direction and are slightly weaker, and inferior fibers, which are transverse. So sorry, I should have said the superior fibers are stronger, the inferior transverse ones are weaker. And that's why you tend to get interstitial tears within the substance of infraspinatus more commonly, because you've got these 2 different fibers running obliquely and transverse. The other thing to note is we often underestimate the importance of subscapularis, but just remember, subscapularis makes up 50% of the rotator cuff strength. So it's a very important tendon and muscle. And the upper 60% of its insertion is tendinous, the lower 40% is muscular. So for me, that's really the anatomy that you need to know for the FRCS. If you then look at the rotator cuff under the microscope, it can be broken down into 5 distinct layers: the coracohumeral ligament, tendon fibers in layers 2 and 3, connective tissue, and finally capsule. You don't really need to know that in detail, but what I would remember is that the cuff is about 1.2 centimeters thick. And that's important because if you're measuring cuff tears intraoperatively, or if you're looking on scans, you can work out about the percentage of how much of the cuff is involved, which can help your management plan. In terms of blood supply to the cuff, it runs between layers 2 and 3, and it runs from the suprascapular, subscapular, and anterior branch of the anterior circumflex humeral artery. And there are also small contributions from the posterior circumflex humeral and also the thoracoacromial artery. So all of those together supply the cuff. It's got a very rich blood supply, okay? The next thing I want you guys to understand is this thing called biomechanics. And I think this is really important for the cuff to understand this, okay? And the buzzword I want you guys to think about is couples. So a couple is a pair of moments which basically are equal but acting in opposite directions. And there's lots of different force couples everywhere in the body which help synchronization or coordination of movements. And the rotator cuff is no different. It has a coronal couple and it has a transverse couple. So I'm just going to demonstrate to you in this diagram here. In the coronal plane, you've got the force of deltoid, which is essentially pushing the head up, and you've got supraspinatus, which is pushing the head down and in. This creates a net joint reaction force, which essentially compresses the head against the glenoid, a process known as concavity compression. So it helps to fix the head against the glenoid. So that's the coronal force couple. And you also have this thing called a transverse force couple, which works between subscapularis at the front and infraspinatus at the back. The two forces essentially are acting and they push the head onto the glenoid, which gives you this concavity compression and helps with stability of the glenohumeral joint. The other way that I remember it is, why do you have these couples? Essentially what you're trying to do, especially with the supraspinatus, is you're trying to create a fixed fulcrum, which is a fixed point on which the deltoid can operate. So I liken it as if you're at the beach, and let's say you've got a beach ball, which represents the humeral head. You're trying to keep the ball just underneath the water with your fingers, which represent the supraspinatus. So the waves represent the deltoid pushing the head up. Your fingers represent the cuff pushing the head down, and the two forces are balanced. But if the cuff goes, you will get unopposed action of the deltoid, and that will lead to superior migration or uncoupling. Okay, so just remember these force couples and this buzzword, the fixed fulcrum. Okay, so we've talked about anatomy, we've talked about biomechanics, the so-called boring parts of the talk. I'm going to now move on to what I think is really relevant to you guys clinically, and that's mechanisms and presentation. So first of all, mechanisms of injury. The first thing to remember about rotator cuff disease is a very broad word, and it's actually a spectrum. Now, a lot of trainees come to me and they say, oh, Rishi, tell us about subacromial impingement, tell us about calcific tendonitis, tell us about rotator cuff tears. And I try and say to them, don't think of these as different diseases. Think of them as different points on a spectrum. So you can start with very basic subacromial impingement, where the tendon essentially gets pinched, frayed, and you get an inflammatory bursitis. And that's sort of subacromial impingement disease, okay? You can also get calcific tendonitis as well. You can then progress to a rotator cuff tear, which you can see on this coronal MRI. And finally, at its most severe, you can sort of progress to frank rotator cuff arthropathy. As you can see here, you've got superior migration of the humeral head because you've lost your force couples. Remember my analogy of the beach ball going above the waves. You've essentially got loss of your acromiohumeral distance. You've got femoralization of the humeral head and acetabularization of the acromion with subsequent arthritis. This is very bad, and it's a situation which is difficult to salvage. But all of these points are different points on a spectrum. They're not separate diseases. So what's the mechanism by which the tendon itself gets injured? And the reality is we don't completely know, and various theories have been proposed. So there's the extrinsic theory, which says that you get some sort of, you've essentially got a normal tendon, but you get some sort of extrinsic or abnormal compression and impingement, which can either occur on the bursal or articular side of the tendon. Or the intrinsic means you've got an abnormal tendon because of some sort of intrasubstance change. So I think of weak tendon and normal tendon. Okay, that's how I remember extrinsic and intrinsic. So let's start with the extrinsic theory. Okay, and as I told you guys, this is when you get some sort of compression which occurs either on the bursal side or the articular side. So on the bursal side, there's studies by Charles Neer in 1982 and Bigliani in 1991. And basically what Neer suggested is that the anterior aspect of the acromion seems to be involved, and occasionally there's osteophytes from the AC joint. He divided the changes in the tendon when it's compressed over time into 3 different stages. So it starts off with simple inflammation, it progresses to fibrosis or scarring, and then eventually to a frank tear. So that was what his proposition was, and why this is an extrinsic compression on the bursal side. He also, a cadaveric study was carried out by Bigliani, and Bigliani found that looking at about 140 shoulders, basically people had different morphologies of their acromions, where the acromions could either be flat, type 1, curved, type 2, or hooked, type 3. And he found that actually almost 3/4 of occurred in the type 3s, the hooked ones, suggesting that the underlying mechanism was some sort of compression. The hook would reduce the amount of space available on the bursal side and essentially compress the tendon. So that was evidence of this extrinsic compression on the bursal side. On the other hand, you can get compression on the articular side, and this is where the tendon essentially gets trapped between the humerus and the glenoid in extreme abduction and external rotation. So that movement there, and it's often seen in sort of overhead baseball pitchers, okay? And it's known as internal impingement. So you get this triad of anterior capsular laxity, posterior contraction, and internal impingement, which was first described in overhead athletes by Gilles Walsh in 1991 and then Job in 1995, okay? So you can see that in this picture here. The person's shoulder is an abduction, external rotation, and essentially the cuff is getting trapped between the humeral head and also the postero-superior labrum in extreme abduction and external rotation. So the second theory I talked to you guys about is intrinsic theory. This time you haven't got a compression, but you've got some sort of problem with the tendon itself. And evidence for this comes from the fact that we see tears more commonly in people as they get older. So there's a suggestion that the blood supply becomes more tenuous with age. We see it in males more commonly than females, suggesting that sex may have a contributing factor there. There may be a link to more type 3 collagen or glycosaminoglycans, and there may be an underlying role for apoptosis as well. So we don't know exactly what causes rotator cuff tears, but this is the proposed theories, extrinsic and intrinsic. So let's move on to presentation. And my role really here is not just to teach you guys about how to pass the exam, but also how to be better surgeons and how to recognize these patients when they walk into your clinic. And my practice is full of these sorts of patients as well. So I'm always on the lookout for them. But classically, the patient will complain of pain. And the pain is typically located in the shoulder tip, and it often radiates down the arm, down the lateral aspect of the arm to the elbow. If it's going down into the hand, I'm thinking of something different, possibly coming from the neck. The pain may also go round to the periscapular region as well, okay? They may have a traumatic or atraumatic history, and that's really important because there's two different types of tear patterns that you tend to see. What I would call the younger traumatics who've dislocated their shoulders, and I've got a much lower threshold to treat those operatively, or the elderly degenerates, where it's just an insidious pain that occurs over time as the tendon gets more and more frayed until it eventually tears. The patient may get night pain when they lie on the shoulder directly, or they may get pain which is exacerbated on overhead or rotatory movements as well. So I would typically ask the patient, does your pain get worse if you have to reach up for something off a high shelf? Does it get worse if you wash the back of your hair? Or if it's a female, does it get worse if you try and put your bra on? These are little things that I will give to the patient because they will understand those better than if I say, is your pain worse on external or internal rotation? If they've got a tear, they may have functional loss or weakness. And then they may get this thing called pseudoparalysis, which is demonstrated in this picture here. So the instruction that's been given to this patient is to elevate both of his arms. But what you find here is that the patient physically can't move the shoulder. And when he does so, the humeral head starts to ride up. And the reason it's called pseudoparalysis is I want you to think back to that thing I talked about with the coronal force couples or the beach ball. Essentially, you've lost your fixed fulcrum. So you've got unopposed action of the deltoid, which is causing the head to sublux or superiorly migrate. So it's effectively moving off its fixed point, and essentially the deltoid cannot operate it properly. When you manage to fix the humeral head down, you'll find that suddenly the patient can move their shoulder a bit more, which is why it's known as pseudo paralysis rather than real paralysis. And you can do special tests as well. And my advice to you guys for the exam would be just pick one test per tendon. There's lots of different shoulder examination tests, and you can read about them all if you're interested, but actually just keep it simple, guys. And I do the same in my clinic. So for the supraspinatus, to test that, I'm doing a Job's test where I bring the arms out in 30 degrees, basically. So it's in the plane of the scapula. I forward flex, and then I turn the arms upside down. I call it the empty can test. So I tell the patient, imagine you've got 2 cans of Coke and you turn the cans upside down, and then I physically try and resist that. And I'm looking for pain and weakness. So that's Job's test, Jobes. Okay, that's for supraspinatus, okay, because it eliminates the effect of deltoid. For infraspinatus, I might get the patient to stand up and say, put your arm by your side, and imagine as if you've got a pound note or something and you're trying to stop it from leaving your arm. Keep the elbow tight to your side, rotate the arm out, and I will try and do resisted external rotation to stop that, okay? So that test for external rotation, infraspinatus and teres minor. If I think they've got an infraspinatus tear, I might test teres minor by getting them to put their arm into an abducted external rotator position, or I would passively put them in that position and I will push against their arm, and that's testing teres minor. If the arm goes down like that and they've got what's known as a lag sign, it's called a horn blower's sign. And that's because the classic horn blowers, they would hold the trumpet like this, and so the arm would fall from there to there. So that tests teres minor specifically. And finally, you can test subscapularis. And so some patients will do the arm behind the back and you stop them pushing it away, which is known as Gerber's liftoff. Some people will do a belly press test where you get them to put their elbows forward, push into their belly, and then you push against the elbow. And basically you're looking to see if they sort of cheat by pushing their elbows back. That's a positive test, okay? So my advice, guys, would be pick one test per tendon, whatever you do. Don't confuse yourselves, okay? You can also do provocative tests as well. And so you might have a Hawkins test, which is basically where you're abducting, externally rotating, and sorry, it's with the backdrop, and you're trying to push the arm down and elicit pain. And what you're doing is you're essentially pushing the great tuberosity under the acromion. You can do a Neers test, which is where, again, you put the arm into forward flexion, a straight elbow, and pronated, and you passively forward flex it up, and you're looking for pain. Or you can do the empty Canton test, Jobes. And these are all signs, basically, of impingement as well as rotator cuff tears as well. Impingement will typically be painful, but not weak, a rotator cuff tear will be weak, okay? So these are the sort of provocative tests that I normally do in my clinic as well. And the great thing about shoulder surgery is you should basically have your diagnosis from the history and the exam before you even touch any kind of imaging. But the investigations just help to supplement your diagnosis and subsequent treatment. So I will always request two views, AP and axillary. So what am I looking for? I've just got the APs here. So basically, you can see here that on the undersurface of the acromion, it's quite white, and that's known as an impingement sign, and it's a sign that it's been getting rubbed on by the tendon. You might also see a little spur of bone as well. On the Grace tuberosity, you can see that it's white as well because it's been rubbing against the acromion, a so-called impingement sign. You can also look at something called the critical shoulder angle, which is defined as the angle between the glenoid surface here and a line connecting the inferior rim of the glenoid to the lateral tip of the acromion. Now, normally the critical shoulder angle should be about 30 to 35 degrees. If it's less than 30, some studies have shown a correlation with glenohumeral arthritis. If it's greater than 35, this may be implicated in rotator cuff tears. So that's something you could comment on. You could also comment on the acromiohumeral distance, which should typically be about 1 centimeter. Remember, this X-ray hasn't been calibrated, but essentially that gets reduced if you start to get to superior migration of the humeral heads. These are all things that I'm looking for on the plain radiographs. I would almost certainly request an MRI. Now, I have worked in units where you can do ultrasounds for your diagnosis, but I find, and that's valid, it depends upon what your specific unit is like and what your relationship is like with the ultrasonographer. But I do find that with ultrasound scans, they're good for diagnosing tears and for doing injections, but they don't really give you much about the nature of the tear itself. And you are very dependent upon your radiographer as well and the interpretation of your radiologist. So I find MRIs really useful. I would always recommend, guys, look at your MRIs yourself. Don't rely upon the report. I never read reports until I've been through the scan myself, okay? Because it's all about looking at the scan in context. And that's where you're lucky over your radiologist, is you've got the patient in front of you, you know their history, you know their examination. So it's much easier to correlate the findings as well and see which findings are clinically relevant or not. So for example, a report might show something like a labral tear, which is just an incidental finding and may be irrelevant. So always look at your reports yourselves, guys, if you can. So I look for 3 views. I get a coronal view, and on that one I can see if there is a supraspinatus tear and also how much it's retracted by. If it's gone to the level of the glenoid, I'm thinking that's bad and it's going to be difficult to repair. So that's the buzzword that I remember. Just check if it's gone to the level of the glenoid. Okay. On the axial view, I can see if there is a subscapularis tear from the front and a infraspinatus tear from the back. So the reason I know that that's the front is because the coracoid is there. So that's anterior. And then finally, on the parasagittal views, you're looking for that Y shape of the scapula. And you look for this nice circle of muscle that you can draw around: supraspinatus, subscapularis, infraspinatus, and teres minor. Okay, that's what you should see normally. Now, when somebody gets a tear, the muscle starts to go down and degrade basically over time. It can basically retract, but it can also atrophy and become filled with fat as well. So what you're looking for is a line drawn across the 2 parts of the scapula. And I think of it like a Mercedes car, a Mercedes-Benz, 2 lines here and a vertical one going down. And ideally you want the muscle to be above that line. If it's below that line, it's what's called a tangent sign. And this was well described by Kissenberth in 2014. And he basically found that a positive tangent sign indicates that often that these cannot be repaired. It was a retrospective study. He looked at operative notes, he looked at preoperative MRI scans and found that actually this had very good inter and intra-observer reliability. So these are the sorts of things that I'm looking for on the MRIs. As I mentioned, you can get ultrasounds as well, okay? We then move to classification. And one thing I've got to warn you guys is if you look in a textbook, you might find about 30, 40 classifications. And so I would just pick about 2 or 3 to learn, which are relevant. I've written these down for you guys here, okay? So the first one is by Kofeld and Diorio, and they basically just looked at the size of tears, okay? So small being 0 to 1 centimeters, medium 1 to 3, large 3 to 5, and massive tears more than 5. Is it that helpful? Well, it can be, just in terms of communicating, so you know what kind of fixation you might require. Oh, I might go for a double row repair rather than a single row, or this might be a longer case. It just helps your planning in your head. You can have a classification for partial thickness tears, and Ellman described these by grade and location. So grade was 1, 2, or 3, depending upon the size of the tear. Remember what I said before in the histology slide. The tear is about 1.2 centimeters thick. So a 1 is 25% thick, 2 is 25 to 50, and the 3 is 50% thick. Also, the location, is it A, articular, and is it B, bursal? And I think this is a good classification because it tells you about partial tears, which ones are worse or have the poorer prognostic outcome. And what it's been shown is that bursal tears tend to do worse. The blood supply is poorer. So what we say is, if you get a bursal tear of more than 25% or 3 millimeters, repair it. If you get an articular sided tear of more than 50%, repair it. So you can be a bit more forgiving with an articular tear. And we call those pastor tears, partial articular supraspinatus tendon tears, okay? Okay, good. So the other classification to remember is about morphology. So the actual morphology of the tear. And you can classify these tears by their tendon geometry. And this is only something you can really determine intraoperatively, okay? So these can be broken down into crescent tears, which means that they easily reduce from medial to lateral. Excuse me, U-shaped tears, which basically means you've got a central component which is contracted down. These will not reduce easily from medial to lateral, and you basically need to fix that side to that side, a process known as marginal convergence. L-shaped, where one of the leaves of the tear is more mobile, again, that will not reduce directly. And these real massive sort of contracted tears where you may need further treatments for those, or they may not be repairable. So I find this classification very useful intraoperatively. And that's just giving you guys it there as well. Okay. The other classification I think is quite nice is this thing called Goutalier's. And Goutalier's, we often quote it on MRI scans, but in reality, it was originally a CT-based classification. And Goutallier looked at the fact that if a tendon becomes torn over time, eventually it will become disused and you'll get atrophy, but you'll also get infiltration of fat. So 1 is where you've just got little streaks of fat. 2 is where you start getting fatty infiltration, but there's still more muscle than fat, so more than 50% muscle. 3 is where it's about 50-50 muscle to fat. And 4 is where you've got more fat than muscle. And the relevance of that is because if you're looking at a tear preoperatively and it's very retracted and there's loads of fatty infiltration, you've got a positive tangent sign, you've got to be realistic to yourself and the patient. And I always counsel them that these may not be repairable. I may have a go, particularly if it's in a younger person, but I will always counsel the patient that it may not be repairable. Or if it's an elderly person, I may just actually not even bother trying to repair it at all. So these are all things which help to guide my surgical management. So I think they're very useful on that front. We finally move on to treatment. And I think this is sort of the crux of the talk, which is quite interesting. How do you treat these patients? And I break it down into decision-making and actual surgical technique. And for me, at FRCS level, that is the most important. In fact, I'd actually change that, not just at FRCS level, throughout your life, even as a consultant, your decision-making is key with these patients, because if you're a poor decision maker, you're going to have poor outcomes. Okay. So decision-making, guys, is the key. So what helps you to make your decision? Well, I break it down into 3 things: patient factors, surgeon factors, and implant factors. And when you're presenting in the vivas, I would talk to the examiner like this as well. And I would further subdivide these patient factors up into external factors. So things like the physiological age of the patient, their occupation, their dominance, their motivation to do the rehab. Are they a smoker? Do they have comorbidities like diabetes or things which may give them a poor response to healing? Are they on steroids? What their injury mechanism is. Was it traumatic or atraumatic? And then also tear factors. What's the nature of the tear? Is it very retracted? Is there a lot of fatty infiltration? Or is it a massive tear which may be difficult to repair? So all of these are patient factors which are going to guide my decision making. Surgeon factors, it will be about the skill set of the surgeon. Are you going to do an open? Are you going to do an arthroscopic technique? And technically how you're going to do it. And implant, what type of anchors or sutures might you use? Are they metal anchors, biocomposite, or PEEK anchors as well? Okay. So remember, guys, the way to treat a tendon is go back to your basic fracture, basic science. Anything to heal needs biomechanics or stability of some sort, and it also needs good biology, okay? And the biology can be patient factors that I mentioned previously, so things like, are they on steroids, are they a smoker, are they diabetic, and things that the surgeon can do intraoperatively to augment their healing as well, okay? So these are all things that you need for a tendon to heal. Keep these in the back of your mind, okay? And one thing I want to mention and touch on very briefly, this is probably beyond the scope of FRCS, and it's if you're going for those gold medals, but I think it's a very easy concept, so I wanted to mention it. Essentially, it's this thing called the cable crescent theory, which was described really well by Professor Burkhardt from the US. So Professor Burkhardt described this concept of a rotator cable and a rotator crescent. So the cable is essentially like a piece of fibrous tissue which acts as a hanging bridge between the two rotator intervals that sit between supraspinatus and subscapularis. And what he said was that the cable is a thick bundle of fibers which is found at the avascular zone of the coracohumeral ligament, which essentially runs perpendicular and deep to your supra and infraspinatus tendons and spans the insertion of the entire part of the tendon. Whereas the rotator crescent is just a thin crescent sheep of tendon, which is where the cuff inserts into the bone. It's the distal part. Now, the reason why that's important is because Burkhardt, in his pioneering paper in 1993 with Ian Lowe, did cadaveric dissections where they basically defined the rotator cable and the rotator crescent and said it was very similar to a suspension bridge. So think of the Golden Gate Bridge in San Francisco. The bridge is basically held up by these two struts, infra at the back and subscap at the front, okay? And you've got the tendon here, which when it falls away from the bone, if you've got intact rotator cables, the tendon will only go down a bit and the person might still have good function. However, if you basically lose the rotator cable or you lose one of these struts here, the whole bridge will fall down. So it's a biomechanic model. And the other thing that Professor Burkhardt and Ian Lowe found was also that their theory was that the cable actually provides an element of stress shielding to the crescent, because the crescent is relatively thin and quite susceptible to tears. So what they said was basically if the tear involves the crescent but not the cable, the patient may actually be biomechanically stable, so they may get no symptoms at all. And you often see this in elderly people, okay, which basically essentially means that they can still basically means that even if they're anatomically deficient, they can still maintain their biomechanics and so they don't have symptoms, okay? Whereas in younger people, basically what happens if they're often dependent upon the cable, so if that goes, the whole thing goes, they decompensate a lot quicker. So Burkhardt and Lowe basically said achieving a biomechanically stable construct is critical to biological healing. So I want you guys to think of those two areas, biology and biomechanics, okay? And I wouldn't go into more detail than that. So why do tendon repairs fail? Because actually, if you look at various books, the failure rate of tendons can be very high. Some of them, especially with the massive tears, it's been quoted as high as 95%. Although remember, healing doesn't necessarily correlate with function. You get some tendons which don't heal, but the patient still gets reasonably good function. Well, implants are so good nowadays that it doesn't tend to be because of an implant problem, like the actual anchors themselves breaking in half. It tends to be because of patient or surgeon factors. So patients might be smokers. They might have degenerate tissue because they've got poor biology. the tendon may be more than 6 months old, so it's now contracted and there's fatty atrophy. Or something the surgeon did wrong in their repair. They didn't appreciate the morphology and tried to repair it the wrong way. So it wasn't biomechanically stable. They didn't restore the biomechanics. And that could be because they didn't mobilize the tendon properly, they didn't visualize it properly, or they didn't fix it properly, okay? So those are your two main reasons for failure. So if we go back to that decision-making again, as I told you, the implants are so good nowadays. These are the ones that we tend to be able to change: patient factors and surgeon factors, okay? So let's start with patient selection. You can look at external factors of the patient. So basically, you want to pick a patient who's got a young physiological age. So they could be 70, but they're very active physiologically. So I don't look at their actual age, I look at their physiological age. You want somebody who ideally is not a smoker, who doesn't have many comorbidities, and also somebody who's sufficiently motivated and able to undergo rehab. Guys, you've got to be realistic with your patients. So I tell all my patients, I say, look, you're going to be in a sling for 6 weeks if it's a moderate to severe size big tear, and you're also going to have to go through about 6 to 9 months of rehab. You may not get back to having a normal shoulder for almost 9 months to a year. I counsel all my patients like that, because when you go in, you might find that the tear is a lot bigger than you thought initially. And actually, if patients think they're going to have a one-stop fix, they're going to be a lot more disappointed. And studies have shown that patient expectations certainly correlates with their outcomes following a rotator cuff repair. You can also look at tear factors. So I look at the amount of retraction of the tear. There was a classification by Pate which divided it into 1, 2, or 3. 1 being not retracted, 2 means that it's gone to the acromion, and 3 means it's gone all the way to the glenoid. So if I see 3 level 3 tears, I'm thinking this is going to be difficult or impossible to repair. They may have associated pathology such as glenohumeral arthritis, fractures, fatty infiltration, or it may be a tear which has been there for more than 6 months. You've also got to always keep this in your mind. Is it a young traumatic tear, such as a 45-year-old patient post-dislocation, or an elderly atraumatic degenerate tear? Okay, I have a much lower threshold to fix these because these guys often are cable dominant. They decompensate a lot quicker. Okay. And then finally, in terms of treatment options, let's say you've been through your decision-making process. You've looked at patient factors, you've looked at surgeon factors. You could go for non-operative or operative. So I would always, with my subacromial impingements or my degenerate type tears, I would always start with non-operative treatment first. And physiotherapy, so that might include rotator cuff strengthening exercises, making sure that you give them good posture and scapular correction, recenter the shoulder, deltoid strengthening exercises, or injections, okay? And so these are the questions I would ask in the exam with regards to injections, and I would have an answer in the back of your mind. So first of all, when do you inject? Well, you can do it for subacromial impingement. And with regards to subacromial impingement, the pathology involves dysfunction of the rotator cuff, resulting in some sort of mechanical impingement and compression of the subacromial bursa between the cuff and acromion and the coracoacromial ligament. So this results in subacromial bursitis, subsequent pain, further rotator cuff dysfunction, and further impingement. So it leads to this vicious cycle or a positive feedback loop of an impingement syndrome. So for me, I would use injections if there's a failure to progress with rotator cuff rehabilitation because of pain. Okay, so the physios just can't get anywhere at all. Okay, and the aims of this injection, it's normally into the subacromial bursa, is to reduce the inflammation of the bursa, achieve pain relief, and allow the rehabilitation to progress. Okay, now the next question is, how do you inject? Do you inject it blind, or do you inject it under image guidance? Okay, so normally I would give it blind in clinic posteriorly. So I feel the posterolateral border of the acromion. I go 1 centimeter down, 1 centimeter medial, exactly like you're doing your posterior portal for an arthroscope. But some people will go laterally as well. Okay, and what they say is that the accuracy is about 76% if you go via the posterior approach, 69% via anteromedial approaches. That was a paper by Henkus, Henkus, in 2006. The ultrasound guided injection is performed slightly differently. So the injection this time is subdeltoid rather than subacromial. And in performing this technique, the bursa is slightly compressed between the cuff and the deltoid. So it reduces the amount of access. So you do need good visualization to ensure it's into the correct place. Okay. The next question is, would you inject for cuff tears? Because some people say, oh, well, if there's a cuff tear, the injection will just escape everywhere and it won't be effective. So I would tend to give an injection for cuff tears as a pain relieving procedure to get them physio. Although if it's a young traumatic tear and I'm going to be going in and fix it, I might just go straight for fixation early on. So it depends upon the patient, but even in an elderly degenerate patient, I probably would give them an injection just to help the rehab. And then the last question is, what would you inject? So there's various different things that we can inject. Most commonly, we give local anesthetic and steroids. So I tend to give Kenalog, about 40 milligrams, and then also Marcaine or Lignocaine mixed together, okay? Remember, steroid can damage the tendon. So I tend to limit my tendon injections to maybe 1 or 2 max. Although in patients who have an irreparable tear, maybe elderly patients who are not fit for surgery, then you could argue about repeating those intermittently if they had a good response. There tends to be a law of diminishing returns, meaning you get less impact the more you inject them. So the second injection may not be as effective as the first, the third even less effective, and so on. You can inject other things such as ostenil or hyaluronic acid, and there was a small randomized control trial by Len Funk in Wrightington, the UK, where he looked at depomedrone versus hyaluronic acid for subacromial impingement, and he said that actually there was no difference in the pain score between the two groups. It was quite a small study, but people would argue that hyaluronic acid doesn't damage the tendon, whereas steroid potentially can damage the tendon and make you susceptible to tears. There's also been experiments and also early studies into PRP as well, but which is basically platelet-rich plasma, but whereas it's very effective for tennis elbows, studies are inconclusive regarding the shoulder, so I don't use that widely at all. So I tend to just use a steroid and local anesthetic for this, but that may be different in different parts of the world as well. So what are your principles of operation? Non-op treatments failed, and I would normally say any patient with subacromial impingement, I'd give them 6 months of non-operative treatment, an injection, at least 6 cycles of physio. A degenerate tear, I'd give them a trial of non-operative treatment first. But if they fail that, or if they've got an acute tear which is traumatic, I tend to go in for an operation early if possible. Okay, and my principles are: I want a tensionless repair. Okay, I want to visualize the tear appropriately. You can do this open or arthroscopic, but I find that arthroscopic gives you much easier visualization. You need to be able to identify the morphology of the tear and classify it appropriately. You need to mobilize it adequately as well, so you can bring it back to the correct position. Imagine as if you're reducing a fracture, you have to reduce the tear. It's exactly the same principle. You want to prepare your bed and also pass your sutures appropriately. And you effectively want to fix the tendon down with sutures, which can be either knotted, knotless, single, or double row. And you want to do some sort of biological augmentation, because remember, it's not just about fixing the biomechanics, it's about restoring biology as well to get these tendons to heal. Okay, so I classically will set these patients up in a beach chair position. I normally sit them up quite vertically, but it depends upon your anesthetist, and you need a good anesthetist, guys. So you basically want to keep the blood pressure low if possible. I normally give adrenaline in at the start to the ports to try and reduce bleeding from the ports. And I use a limb positioner such as a Tremano or a spider attachment, basically because it's the best assistant. It's not like a registrar, it doesn't get tired, and it helps to put the arm in good positions as well. But there's lots of different ways to do this, okay? I will typically mark out the portals, and this is a picture I took from Google Images, but you typically have your posterior portal, which is your viewing portal. So you find the posterolateral border of the acromion, you go down and in by about a finger breadth, okay? I don't say down and in by a centimeter because it depends upon, if you've got a big muscly patient, you might go down and in a bit more. So it depends upon the size of the patient. So that's my viewing portal. That's my rotator interval portal, which is just lateral to the coracoid. So that can be if I want to do my surgical releases. That's my anterolateral portal, which is classically where the tendon is. And then that's my lateral portal, which is classically my operating or working portal, which I will often do. Sorry, I should have said, I will often, once I've looked from the back, I will often mobilize the tendon, and then I will move the camera here and fix it using that portal. So I'll classically do 4 portals for these cases. So I mentioned to you guys about tear morphology, and I want to discuss this in a bit more detail. This again, guys, is probably beyond the scope of FRCS. It's probably looking at fellowship level or getting a gold medal, but it's really easy, so I'm just going to mention it very briefly. A crescent tear is the easy tears. These are your GCSE tears. These are where it easily reduces from medial to lateral. So you pull on it through the lateral portal with your probe, you bring it that back, or your grasper, you bring it back, easily reduces, fix it. Crescent tear, okay? A U-shaped tear tends to be when the central part of the crescent has become contracted down. Now, the problem is, if you just pull this up and try to fix it, it wouldn't work. It would bunch up, okay? So basically what you have to do is fix the 2 sides together, and that's called marginal convergence, and it turns the U-tear into a crescent tear, and then you fix it up there like that, okay? An L-shaped tear is where you've got one leaf of the tear which is more mobile than the other one. And it can be a L-shape or a reverse L-shape, depending on which leaf is more helpful. Again, if you pull that, it won't reduce. So you have to fix it first with sutures known as marginal convergence. And then that turns it into a small crescent tear. And you then just fix it in a medial lateral direction. Okay. This is a massive contracted tear, and these are probably the hardest ones to fix. And with these ones, you often have to basically make a plane between the tendon and the rotator interval, which is called an interval slide, to try and mobilize this segment here. You then bring that back, convert it into a U-tear like this, and then fix it by marginal convergence, and then turn it into a crescent tear. It's a really difficult tear to do. It has a very high failure rate. But those, what I would learn for the exam is the 4 types: crescent, U, L, and massive. I don't think you need to know any more detail than that. Okay, so I've looked inside, I've visualized my tear. The next thing I want to do is I want to prepare the bed, okay? Remember what I said, guys. It's about preparation, preparation, preparation. You need biology. So you have to recognize the footprint. And this was really well described by Mochizuki et al. In the JBJS America in 2008. And he described about the footprint of supraspinatus. It's quite large, it's about 2 by 2 centimeter. There is some overlap with infraspinatus as well. And so he said you have to prepare the footprint adequately. You need to basically shave the residual tendon off it, and then you need to decorticate it with a burr to get it to bleed, so that when you pull the tendon back and fix it, it heals properly. The next thing I want to do is so I've identified the tendon, I've classified the tendon, I've mobilized it, I've done all my releases so I can mobilize it adequately, I've prepared my bed, I then want to pass my sutures. And there's different ways of doing it. You can use a scorpion and pass the sutures antegrade through there, and then you pull it back to the bed. You can do what's called a suture passer type technique, where you use something else, a little loop of suture, and you pass your threads through that, through the tendon. Or you can do a retrograde one, which you use something like a rhino, pass it through the tissues, and then pull the threads or sutures through that. And that's really useful for your marginal convergence, which I mentioned previously for the U-tears, okay? All different ways of skinning a cat, all equally effective, okay? Antegrade, suture passer, retrograde, okay? And then what are your operative principles of fixation? Well, basically, we tend to use an anchors, and these anchors can be either ones which screw in, or they can be interference ones where you knock them in like that, okay? And it can either be single row or double row. So single row means that you just have a single row of anchors, okay? Double row means you've got 2 rows of anchors. And there was different generations of these described. So a conventional double row is where you tie medially and you tie laterally, separate from each other, okay? The problem with these is you didn't restore the footprint very well. There was a lot of strangulation of the tendons, and it could take a lot of time. The transosseous one is where you tie medially and you have not less laterally, okay? Again, there is some question over medial tendon strangulation, although some people would argue you've got 2 points of, you've essentially got more points of fixation. So basically, if that fails, the lateral ones, you've still got the medial ones tied down. or there's these knotless ones. The Speed Bridge by Arthrex is an example of these. And basically, the advantage of these is it's knotless, it's a lot quicker. See, some people say there's no strangulation of the tendon, but others argue that there's lower construct strength, and basically you've only got it fixed here and fixed here. So if that gives way, the whole construct will give way as well. Lots of different ways of skinning a cat. And for me, the most important is the decision making. If I've got a small crescent tear and I pull it back and there's no tension whatsoever, it really easily comes back. I'm just going to do a single row. Okay. Studies have shown that there's no real difference between single and double rows unless you have massive tears. For massive tears, large tears, I would definitely use a double row because I would just want that sort of belt and braces type thing. Okay. So I'm going to go back again. We've visualized, we've mobilized, we've identified the tear pattern, we've prepared our bed, we've put our sutures, and we've fixed it. What do we do next? Well, I would normally end off by doing some sort of biological augmentation. I've restored the biomechanics, but I want to try and encourage biology. Often after a tear, these are avascular patients, elderly patients. They've got poor biology. So you want to try and get some bleeding to get the tendon to heal. So you might microfracture the bed. You might use a little oil just to make little holes. Okay, or you might even just shave the bed or with a burr very slightly debride it. You might use vented anchors, which allow bone marrow and bleeding to basically come up through from the bone and come onto the tendon. Okay, and this technique here was described as a crimson duvet by Steve Schneider, because once you've prepared the bed, you see all this bleeding on the tendons. So you see this red appearance. Or you might use a biological patch. These tend to be newer, and sort of the efficacy of them is not completely known. But I have worked for people who've used biological patches for large tears as well, and they can be useful for that. So in conclusion, thanks for staying awake through that. Basically, early recognition is the key with rotator cuff disease, and particularly tears, okay? The earlier you get in there, the easier it is. You've got to assess these patients clinically and radiologically. And my take-home message was, you should be able to get the diagnosis clinically before you even x-ray the patient. MRIs I tend to find slightly more useful than ultrasound. Decision-making is the key. Remember, patient factors, surgeon factors, implant factors. The first two are more important than the last one. Technique always comes after decision-making. If you make the wrong decision intraoperatively, you fix the tear the wrong way because you thought it was the wrong type of morphology, you don't prepare the bed, you don't visualize properly, you don't mobilize properly, all of that will come badly wrong for you, and you'll have a bad outcome. Okay? And finally, with techniques, think biomechanics and think biology. Guys, thank you very much for listening. As Hitesh mentioned before, if you need any more information, that's my website, letstalkdoctor.com. We offer lots of courses, videos, and that's me on Instagram, Twitter, and Facebook. Please check me out. Please send me any questions, any things you're not sure about. Very happy to help you guys at any time. Thank you, Hitesh.
Thank you, Rishi. Yet another fantastic lecture from your side, and you keep the audience very much engaged. Thank you for that. Have come up. I'll just go through some. And
yeah, please. Yeah.
Mr. Senthil is also there in this Zoom.
Hi, Senthil.
Yeah, and I'll ask one of the questions that have come up is, Rishi, looks like you're a big fan of arthroscopic cuff repair. Now, there's a big trial that was done in the United Kingdom itself, the UCuff trial by Andy Carr, the editor of the Bone Joint Research. Looked at patients, 135 versus 137, and they looked at open versus arthroscopic, and they compared the re-tear rates, and they looked at Oxford shoulder scores, and they found that there's no real difference between
there isn't. Yeah, I think
repair.
Yeah, sorry, that's something I should have mentioned, guys. So it looks from my talk that I'm very much in favor of arthroscopic repairs. What I would say to you guys is actually I use open a lot as well. I think there's a place for both. As Hitesh mentioned, Andy Carr's paper showed there's no difference between the two. I worked for a guy in fellowship who would do all of these open. But what he did, which I like to use, is I like arthroscopy just for visualization. So what I will often do is I will go in, have a look with the scope, do my releases, and then I'll see if the tendon comes easily. And if it does, I'll fix it there. The problem with arthroscopy is you've got time limiting factor. It's difficult because the shoulder swells up. As you said, what I will often do is I'll often make a mini open And then once I've visualized it, once I've done my diagnostic or I've mobilized it, then I'll do open to fix it. So I do a combination of the two. And as you said, both are equally effective. I've worked for other people who just visualize it open, but even talking to some of the pure open surgeons, most of them will tend to do a diagnostic first because they often find they don't get quite as good visualization. And I think the other reason you could argue for having arthroscopy is it helps you to look for other pathologies in the shoulder. So you can look at, sometimes it's useful, even ignoring the tear, I will do my diagnostic. And if I find that there's a lot of arthritis, I won't even touch the repair. Because the whole thing you're trying to do, Hitesh, is you've got to restore that fixed fulcrum, pushing the head down and stop it migrating. But if it's already migrated and you've already got arthritic changes, it's no point restoring the cuff. All you're going to do is you're going to put them in a sling for 6 weeks, put them in 6 to 9 months of rehab, and they're just going to be in pain. You're not going to restore their function. So that's a very long-winded answer of saying it's absolutely dealer's choice. There's no difference between the two. And actually, I would probably combine both methods. I think they're both equally effective.
Okay, thank you for that. The other one was another really very important paper that was published in a high-quality journal on the role of subacromial decompression. And
Yes.
they found that there's no major difference between.
No, there's no, and I think, and I probably didn't touch on that as much, because I looked mainly at rotator cuff tears. But I think, first of all, it's important to understand about why we do subacromial decompression in the first place. The theory is, let's say there's no tear. Let's just say it's a bursitis and it's a subacromial impingement. The theory is the tendon is basically getting trapped by some sort of compression. That's the extrinsic theory. And what we believe is that it could be because of the shape of the acromion, and it could be because of the coracoacromial ligament. So what we say to people is you go inside, you take away all that inflamed bursa, okay? And then what you do is you basically shave away part of the bone, and you just take away the spur of bone, and you also release the coracoacromial ligament. And it tends to be done in a sort of cutting block technique, what's called a Kaspari technique. However, you're absolutely right. It's very controversial for rotator cuff tears because people will say, well, it causes swelling of the shoulder. Is it absolutely necessary? And you're right, there's no evidence. So I tend to be in that group of people that I will do a bit of a decompression at the end of my procedure, okay? And I do it for 2 reasons, okay? So number one, it helps the biology. It gives me a bit of bleeding. So the bleeding from the bone itself. My theory is that, with Steve Schneider's crimson duvet, you're giving some bleeding to this tendon, which was previously avascular. And number 2, it gives some more space to my repair. Do I have any evidence for this? No, not at all. It's one of those things that I call orthopedic voodoo, which is where you pass down things from each other and you have your own insecurities. What helps you to sleep better at night? So if I've spent 2 hours doing this repair, for me just to take a little bit of bone away that I think might push against my repair, it's an easy thing to do. Yeah, absolutely, you're right. There's no real evidence regarding it.
And the third thing, what I want to discuss is about the Codman's critical zone. We know that there's a zone of hypovascularity in the distal part of the supraspinatus. And that is one of the reasons why tears are more common in supraspinatus close to the insertion. What is your take on that?
And you're talking about, is that in the sort of crescent bit, the bit where it just inserts into the bone?
There was a lot of talk before on a small area of hypovascularity, called the Codman's critical zone. And do you think that is one of the main reasons that the cuff tears occur in the supraspinatus?
I'll be absolutely honest with you. I'll probably open that up to guys. I'm not completely sure. I think definitely we see tears in a certain area. We see them in the crescent area. It may be because the fibers are thinner. It may be because it's hypovascular. We also tend to see it on the anterolateral part of the cuff. And some people believe because that's where the acromial spurs occur as well. I'm not completely sure. I mean, whenever I do a tendon repair, what I tend to do is I would debride away the distal part of the tendon anyway. I would tend to do that. And I would also tend to rough up the surface and get it to bleed. So that my theory is that that's a relatively avascular zone. So that's why I do that. The tissue quality is not as good. And I have seen that intraoperatively when you grab the tendon, often the distal part, the crescent, is quite poor fibers and you just have to basically debride it away. But I'm not completely sure there. I have to be honest there, guys.
Senthil does a lot of cuff repairs and he works in the States. He's a consultant in Dallas, Texas.
What's your view on that? What would you think?
Well, rotator cuff is always like ever-changing field. Like the way I started 12 years ago, I was fixing everything. I was doing subacromial decompression. I was offering it to everybody, quite liberal with my shotgun approach of going in and taking care of the subacromial space, rotator cuff, labrum, and biceps, and the AC joint. It's like I go there, take care of everything. Now I'm kind of lot more specific about, I need to have a clear-cut diagnosis and establish a source of pain before I go in there. So, and also with the tears, I've become a lot more conservative. Like the small focal tears, pinhole tears, I don't repair them. Sub-centimeter tears, non-dominant hand, I don't repair them. So how do you manage the sub-centimeter or the small intermediate grade tears? Do you follow them up with a surveillance program? Because there's data accumulating that there's going to be a significant tear progression over years.
It suggests that within 2 years that like most of them a lot of them will progress. I say this because with the States as well, I'm not sure what the system is like here, but with the UK, there is a pressure on us that we can't indefinitely follow people up forever. So unfortunately, because obviously it's public funded. So I would tend to sort of, with these small tests, particularly degenerate ones, I will always give them injections. I'll give them physio, and I'll give them a good period. I'll give that at least 3 to 6 months of trying that first. And then I see if they're progressing or not. If they're not progressing, then I'll have that discussion with them. If I think it's a good candidate, I'll say, look, we can go inside. We can, at the very least, we can debride the tendon, do a bit of the subacromial decompression and try and repair it at the moment. Do I follow them up after that? Probably not. It's either one outcome. It'll either be down the line of repair if conservative has failed, or it'll be discharge and then just come back in the future if there's any problem. But it's just, I don't know if my managers would allow me to indefinitely follow these people up. And to be honest, I know that's probably not the right answer, but that's probably the true answer.
I tell my patients that, like there's a chance of tear progression, and I ask them to talk to the primary care about a possible repeat MRI around 18 months to 24 months if possible. But I don't follow them up, so it's like, yeah.
One thing I was going to ask you, Senthil, because obviously working in the States, I don't know what your take is on the patient population, but I did one of my fellowships in Australia, and in Australia, it was literally like 75-year-olds playing tennis. So their expectation was very different. So in the UK, you'd see 75-year-olds, pseudo-paralytics, and you'd be like, literally, they'd be happy with that. People would come in Australia and they'd be like, up here, 75-year-olds, they'd be really unhappy. Like, doctor, I can't, my overhead serve is not right. So they tended to be a bit more aggressive there. That's what I found in terms of their management. They'd go in and repair people who I would never think of repairing. And I think that's part of my decision making as well. The patient versus, it really depends on the pre-morbid state and all that kind of stuff.
Yeah, that's very true. Like there is a difference in the practice pattern and the cultural aspects. I was in the UK for a while before I moved to the US, and like the access to the care, they do not have to go to a primary care. They can directly go see a specialist in US, and then so they are more likely to end up with the surgery, and they are a lot more like active in their 70s. So yeah, that's a really important factor. And that's one of the reasons why we don't have that many frozen shoulders here. When I was in England, I used to see a lot of patients because they don't seek care, or, like they go through all the process by the time they come to the specialist. So
this is what's worrying me about COVID as well, because we've just got a whole cohort of patients now who I think are going to have frozen shoulders, are going to have pseudo-paralysis. I mean, I had some patients already on my list who were pseudo-paralytic. And now your concern is that these patients, are they going to even be salvageable? So I think generally shoulder surgeons, we're going to see a very different group of patient population as well now because of COVID.
But having said that, there was a study from Japan that showed that people who have stiffness are less likely to have a bigger tear, so.
Yes, because stiffness is actually your friend, isn't it, in some way?
Yeah. So
what's your take? Oh, sorry, Senthil.
What's your take on partial tears? How aggressive are you with it?
Again, it depends upon. I mean, some people go on about the bursal versus articular side. If it's bursal, you'll be a bit more aggressive. I tend to that 50% and 25%. It tends to be more of a theoretical thing. In reality, I will again just go down the line of patient and surgeon factors. If I think it's a patient who's very active, who's tried conservative measures first and failed, I will go in I will try and debride properly, define my tear properly. And if it's something that I can easily repair, I'm like, okay, I can see that. Then I'm kind of like, well, if I'm there, why not repair it? Do you know what I mean? If it's only a partial tear, small tear, then I can still be a bit more aggressive with my rehab. So I might not do sling for 6 weeks. I might do sling maybe for 2 weeks and get earlier rehab if it's a small tear. But yeah, I'd say that I mean, obviously I have a lot less experience as a operating consultant than yourself. So I'm probably still learning on the job, but I would do a case-by-case basis, and I would see what their level of activity is and if they failed conservative treatments more often. The other thing I was going to ask you actually is, because with partial tears, do you repair in situ or do you take it down and make it a full tear? Because that's a question.
It depends on whether it's the articular surface or the bursal surface. Bursal surface, I take it down and repair. Yeah. Articular surface, I try to repair it in situ.
Yeah, bursal I tend to be more aggressive with. Definitely I'm more, I don't tend to look at that 25, 50%. I just look at, okay, if it's a bursal tear, I tend to be more aggressive.
That's right. I agree.
Rishi, there's a question from the audience. His name is Dr. Manish Diodhar.
Yes.
And, his question is, what is the rotator interval and what is its significance in today's practice?
Okay, so the rotator interval it's actually got different boundaries, the rotator interval, but I'll keep it real simple. It sits between the supraspinatus and subscapularis. It's tissue between the two of those, and it's actually very useful in terms of it can be a point to put your anterior portal. So for example, if you want to do your releases, you can come through the rotator interval safely. You can use the rotator interval if you're doing a stabilization procedure. But conversely, the rotator interval can become scarred and contracted in a frozen shoulder. So it consists of, for example, the superior glenohumeral ligament, the coracohumeral ligament. These are all part of the rotator interval. So we can utilize it as a portal, but again, it can be a source of pathology in frozen shoulder. So different people I mean, I've worked for people who will release the rotator interval routinely with every cuff. I tend to not release it for everyone. If it's an easy tendon, I can easily bring it back and the interval's not scarred, and I try not to violate it too much if I don't need to. So I don't always make those 4 portals that I was saying to you guys. If it's just an easy lateral crescent tear, then I don't bother making an anterior portal, because the more portals you make, the more swelling you get, the more difficult it gets. But yeah, for a frozen shoulder, that's when you need to really take all of the rotator interval. For a massive cuff tear, if you're doing a subscap repair, I would take the rotator interval because it helps mobilization as well.
Rishi, another question is, what is the role of a acromioplasty while you're doing an open rotator cuff surgery? Because we know that Charles Neer has described a few guidelines. I mean, it's quite old, but still, like resection of the coracoacromial ligament and a small segment of the acromion as well. What do you think is the relevance of those principles in today's practice?
Are you talking about open or for any kind?
Yeah, open.
Again, I think it comes down to and these are just my thoughts. So please, Central, feel free to jump in as well. Like my thoughts are, if you look at the tear pattern, typically it's on the anterolateral. If you're looking for a tear, it's the anterolateral border of the acromion, because that's where you get the spony spurs. That's when you get fraying of the tendon. So I would want to at least take the anterolateral acromion if I can. Even for open, how do you do it? Sometimes you can get an osteotome and just take it away there, or you can use a very small burr and take it away. I think it helps the visualization. I think it gets you a bit of bleeding as well. I mean, that's my view on it. I would take it as part of my practice.
Senthil, what about you? Do you do open?
I do mini open, where I don't take. I mean,
what I mean is mini open.
Yeah,
mini open. Yeah, but I am kind of gone back on acromioplasty. You know, like I do a modified acromioplasty. There are 3 components to the acromioplasty. One is taking the coracoacromial ligament from the undersurface. 2 is taking care of the bursa, and 3 is taking care of the bony part. I've reduced the bony part of it. You know, I kind of stay with the soft tissue part. I take the bursa out. I take out the undersurface coracoacromial ligament. If possible, I don't release the coracoacromial ligament. Only when I feel like it's really tight and there is a traction spur, then I may release it and take care of it. You know, not routinely do a bony part.
I would agree with that as well. So I've become, before I started my fellowship, I was very, very aggressive, like big acromioplasties and all this sort of stuff. Then I worked for a surgeon in Edinburgh, Julie McBurney, and she was an excellent arthroscopist, and she showed me about being a lot more conservative. And so again, I would really do a really good bursectomy. Make sure you take that posterior bursal curtain, really make sure you can visualize cuff, get confident with the shaver so you can shave right down almost onto the cuff, you can see it, and then just do a very slight acromioplasty if there's a spur. If there's not a spur, then it's no point. You don't need to. You can just even use the shaver and just rough it up. You don't need to take bone. And again, CA ligament, if it's a subacromial decompression or a small tear, I will tend to try and release the CA ligament. I won't cut it. I'll just release it off the bone just so I can cut that bone away. But for a large tear, I certainly would try not to release the CA ligament, because there's a theory that the CA ligament can provide some sort of superior restraint as well. I don't know if that's true, but it's what we've kind of been taught. So I try and preserve it.
The other thing is regarding massive tears. What is your take on superior capsular reconstruction versus muscle transfer? I mean, when there's no arthritis, I'm not talking about an arthroplasty or a reverse shoulder, but we have a massive tear. What is your take on muscle transfer versus
I think with
capsular reconstruction?
I think with tendon transfers, you're referring to probably a lapiscopo procedure, it's called, and you're basically using something like latissimus dorsi. They tend to be reasonable for if the main problem is external rotation. So if you've lost infraspinatus or something like that, but I haven't seen many muscle transfers, effective ones, to replace supraspinatus. I have to be honest, I've assisted in lots of superior capsular reconstructions. I've not done one independently. What's your take on that, Senthil, with the superior capsular?
I've done a handful of SCR cases, so I even have some of my friends who have had a SCR from somebody else, and they're doing well. So I do kind of, and it is really, I've jumped on it when the data on SCR was picking up, because we have a bunch of young patients with a massive retracted tear. So I'm quite liberal with the SCR, instead of telling them that, okay, wait till you get old and have a reverse shoulder. I do not mind having a go at SCR.
I'm the same. So for example, if I get these really big, massive cuff tears, pseudoparalytics, if I think it's beyond my scope to repair it, I'm going to refer it to somebody who does SCRs. My plan is to build up to SCRs in the next sort of 2 years, but I want to sort of really develop my practice first, get good at doing cuff tears, and then build.
Yeah.
I wouldn't take them on as a year one consultant, because I think it's something that you need to have done like 500 cuff repairs, and then you build up to SCR as well. So
patient selection is very important for SCR. You cannot do it for somebody who is kind of having a lot of heavy demand on the shoulder and a dominant hand. You got to be that's the key for the patient. We have to kind of prepare them for what they should expect. So. Yeah, but they do well. They do reasonably well.
I saw a lot on fellowship. They were doing really well, actually. They were doing very well.
And it bites you the time. Is it an all arthroscopic technique that you follow for SCR?
You can do it all arthroscopic. The medial side have to be arthroscopic, because you're accessing the glenoid. Open is hard. So the medial side, the medial row, anchors are going to be, the medial glenoid anchors are going to be arthroscopic. The lateral, it's the choice. Some people do it all arthroscopic. I used to do all arthroscopic. Now, once I anchor the medial side, then once I pass the graft in there, I use the suture passer, scorpion, things like that to pass the sutures, and then I tie them down like a rotator cuff repair. So that's what I do. So the difficult part is if you open, then you have to also do like a marginal convergence posteriorly and a little bit anteriorly. That becomes a little difficult. So all arthroscopic is slightly better, but it's kind of suture management sometimes could be a challenge, So
yeah, have you used the facial ladder to bridge the defect anywhere, or what is the material for SCR? Of course, you have the company provides
Arthroflex. It's Arthrex comes with Arthroflex. So it's pretty tough. You can't pass a needle through. So it's not like the graft jacket. So it is to substitute, not the supplementary repair. So it is a pretty tough, and it's a superior restraint. So you can't. It has to be the right size. If it's too loose, it doesn't help, and it bunches up, and it causes more impingement. So you got to have if you are to choose between a tight repair and a loose repair, you better have it very tight. So it will stretch out with time.
The other thing I was going to say is with an SCR, you have to make sure when you examine these patients that they have some either infraspinatus or teres minor and at least a repairable subscap. Even if subscap's torn, it has to be repairable because you need something to fix it at the front and something to fix it at the back. So this is all part of your patient selection. You don't want arthritis. You don't want someone who's going to be doing stupid, crazy things. You want someone who's got at least some teres minor or infra and a repairable subscap. So it tends to be, in my practice, we've been sort of, the ones I've been referring for SCRs have been sort of 50-year-olds, people who I think are a bit young for reverse, that kind of age group and stuff. So.
I think there are no more questions, and it has been a pretty long session, and I've taken both of your times. I mean, it's pretty long. I mean, it's all 11:30 for me.
Sorry, guys, I took a long time.
No, it was a good talk, Rishi. It was a really good talk. You know, it's a very difficult topic because there is so much data accumulating for either way. You know, so you either you repair, you don't repair for everything. You know, so it's a very clear talk.
I think that's the important point to note as well, and that's the point I want to make for you guys at FRCS level. Is this? It's like going down a rabbit hole. Each topic you can ask 5-10 questions, and you can argue each way. And there's a different paper for each of them. Everything you said, like which anchor, how many anchors, which material, open or arthroscopic, this, and you've really got to keep it simple for the exam.
Yeah.
I think it's a fascinating topic. I love reading about it, but for the exam, you guys have got to keep it about the decision making. Keep it simple, because otherwise you can just get lost. You can spend 3 months reading all these papers. You know what I mean?
Yeah, I did a review article in 2015 on rotator cuff. You know, like when I was going through all the evidence and wrote an article, evidence-based approach to rotator cuff repair. Oh yeah, you should see the amount of evidence we have. So you need to know where the source, what's the source of evidence and the power of the study and everything. You can't just go by just papers, you know. So
yes. Can I ask you one question, actually, Senthil, as well? Is what is your sort of theory? You know Burkhart's suspension bridge theory. What's your sort of take on that?
You know, like it's got. Yeah, that's it's very true. You know, like you have patients, but the only thing is, I don't know if suspension bridge is the only thing or is the patient factors like the activity level, dominance of the hand, smoking also playing into that. It's the only way to find out is get a good patient, non-dominant hand, small tear in the, you know, like where the cable is still intact, and see if they have they're more symptomatic or if they're progressing more. You know, that would be a good way to look at it. But I think there is some truth to it. But there are other factors coming into play, you know.
Great, brilliant. Thank you. Thanks.
Okay, Rishi. So shall we wind up? Thank you for that fantastic session. And Senthil, Rishi is a very prominent speaker, and he speaks all for the FRCS courses in the UK. He's a very busy man, and he runs his own enterprise.
Oh, that's great.
So thank you, Rishi and Senthil, for joining us.
Thank you, Ritesh. Okay, take care.
And we end the meeting. Bye-bye.
Okay, bye-bye.